Ladies and gentlemen, welcome to Cardiology Vibes YouTube channel. My name is Dr. Aurangzeb and today I am going to present right ventricular failure, its pathophysiology, diagnosis and treatment. If you have interest in cardiovascular medicine, I will request you to please subscribe to this channel and press the bell icon to stay notified. So let's begin our lecture. The outline of today's presentation, I will briefly go through these topics one by one. Introduction to the right ventricular anatomy, physiology and pathophysiology, the anatomical and physiological particularities of the right ventricle, causes and pathophysiology of right ventricular failure, diagnosis of right ventricular failure, medical treatment of acute right ventricular failure, and in the last section I will go through some advanced options in patients who have refractory or end stage right ventricular failure. The prognostic significance of right ventricle is recognized in many conditions. Recent advances in imaging techniques have created new opportunities to study right ventricular anatomy, physiology and pathophysiology, and contemporary research efforts have opened the doors to new treatment possibilities. Optimal management should consider the anatomical and physiological particularities of the right ventricle and include appropriate imaging techniques to understand the underlying pathophysiological mechanisms. The treatment of right ventricular failure should include rapid optimization of volume status, restoration of perfusion pressure, and improvement of myocardial contractility and rhythm, and in case of refractory right ventricular failure, mechanical circulatory support. In this slide, I will briefly go through anatomical and physiological particularities of the right ventricle. As from the anatomical perspective, the right ventricle is coupled both to the systemic venous return and to the pulmonary circulation. It receives blood from the inferior and superior vena cava that is channeled through the right ventricle and tricuspid valve into the right ventricle, which pumps the blood through the pulmonary valve into the pulmonary circulation. But in contrast to the left ventricle, only a quarter of the left ventricular work is needed to pump blood into the pulmonary circulation, and that is because that the pulmonary vascular resistance is far much less compared to systemic vascular resistance. Therefore, the RV needs fewer muscle fibers and is much thinner than the LV, having about 1/3 of the thickness. Therefore, RV is much more compliant and is slightly larger, approximately 10 to 15% than the left ventricle. So hence it allows the right ventricle to accommodate large variations in venous return without altering the end diastolic pressure. Anatomically, the right ventricle can be divided into 5 parts: the inlet with the tricuspid valve, chorda tendini, at least 3 papillary muscles, the trabeculated apex and the infundibulum. From imaging perspective, the right ventricle is divided into 4 segments: the infundibulum and the anterior, lateral and inferior walls. Right ventricle is very sensitive to changes in afterload. When there is an abrupt increase in afterload, there will be right ventricular dilatation to maintain stroke volume. For example, in patients with acute pulmonary embolism. Another important entity that is very vital in understanding the right ventricular pathophysiology is the ventricular interdependence. And by ventricular interdependence, we mean that there is compression and deshaping of the left ventricle as a result of increasing right ventricular volumes that are constrained by the pericardium. This will in turn reduce the left ventricular stroke volume indirectly. A few points about the right ventricular blood supply, because it carries a prognostic and as well as etiological significance. Majority of the right ventricle is supplied by the right coronary artery, which supplies the right ventricular free wall and the posterior one-third of the interventricular septum. The left anterior descending artery supplies the apex and the anterior interventricular septum. The right ventricle is perfused both during systole and diastole, and this is in contrast to the left ventricular perfusion, which mostly occurs during diastole. And the other difference is that the collateral vessels supplying the right ventricle are more denser than those of the left ventricle. Both ventricles share the septum, and up to 40% of the right ventricular systolic function is dependent on the septal contraction. So this is another important entity. With each systolic contraction, there is primarily longitudinal shortening of the right ventricle, whereas the left ventricular contraction is more circumferential. So from imaging perspective, this is a schematic diagram depicting the parts of the right ventricle, and we can see that this is the tricuspid valve, this is the inflow tract, this is the apex of the right ventricle, this is the membranous part of the interventricular septum, the infundibulum, and the pulmonary valve. This is when the right ventricle is opened anatomically, and this is the trabeculated portion of the right ventricle. This is the inlet portion. These are the cusps of the tricuspid valve with the chordae. These are the chordae, and these are the papillary muscles. This is the outlet portion, the pulmonary valve, the superior vena cava, the right atrium, and this is the atrioventricular groove. Now let's switch gears and move to causes and pathophysiology of right ventricular failure. When we talk about right ventricular function, it depends upon the preload, that is the venous return, the contractility of the right ventricle, the afterload, that is the pulmonary vascular resistance, the interdependence that we already talked about, and the heart rhythm. So any pathology occurring in these 5 entities can lead to right ventricular failure. Again, this is a diagram that shows us the mechanism of right ventricular dysfunction. If there is abnormal preload, if there is reduced contractility, if there is altered interdependence, if there is altered rhythm, if there is increased afterload either from the left heart pathology or because of lung conditions, any abnormality will lead to right ventricular dysfunction. And now we are going to dive into a bit details of the possible abnormalities that can lead to right ventricular failure. So if the underlying mechanism is increased afterload, the possible causes may be left ventricular backward failure, pulmonary hypertension associated with left heart diseases, or it can be because of pulmonary embolism, chronic thromboembolic pulmonary hypertension. It can be because of pulmonary artery hypertension, exacerbated chronic pulmonary disease, acute lung injury or acute respiratory distress syndrome, sleep-related breathing disorders, obesity, hypoventilation syndrome, mechanical ventilation, and repaired congenital heart diseases with systemic right ventricle or right ventricular outflow obstruction. If the cause is reduced contractility, the mechanism is reduced contractility. The possible causes of reduced right ventricular contractility are right ventricular ischemia or infarction, right ventricular injury, systemic inflammatory response, myocarditis, cardiomyopathies, for example, dilated cardiomyopathy or hypertrophic cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy or Olds anomaly. If the mechanism is abnormal preload, the possible causes are hypo or hypervolemia, left ventricular forward failure, pericardial tamponade, mechanical ventilation, and chronic left to right shunts. The mechanism is interdependence, and the possible causes may be pericardial tamponade, pericardial disease, or septal shift. Altered rhythm may be because of brady or tachyarrhythmias. Aside from that long list of pathophysiological and etiological causes, for simplification, we can divide right ventricular failure into two groups, that is right ventricular failure in cardiac diseases and right ventricular failure in pulmonary diseases. First, we will talk about right ventricular failure in cardiac diseases. And the first mechanism is increased afterload. So if a patient has left ventricular systolic or diastolic dysfunction, or patient has post-capillary pulmonary hypertension, these patients can ultimately develop right ventricular failure. Similarly, various forms of adult congenital heart diseases and palliative or corrective surgical procedures such as RVOT obstruction and chronic volume overload may be the underlying cause in such conditions that ultimately can lead to right ventricular failure. Global cardiac diseases that also involves the right ventricle, such as cardiomyopathies, ischemia, myocardial diseases involving the left ventricle, pericardial diseases, and iatrogenic right ventricular failure, especially in patients with mechanical ventilation, and RV ischemia post-cardiac surgeries. The second group of patients who have right ventricular failure is secondary to pulmonary disease, and classically patients who had right ventricular failure due to pulmonary disease, the condition was labeled as cor pulmonale, and it can be acute or chronic. Acute cor pulmonale usually occurs in acute pulmonary embolism when more than 50% of the vasculature is blocked. The right ventricle has to overcome higher mean pulmonary artery pressures, leading to right ventricular failure and obstructive shock. In certain instances, the right ventricle can tolerate acutely elevated higher pulmonary pressures if it was exposed chronically to higher pressures. Chronic cor pulmonale most commonly occur in chronic obstructive pulmonary diseases, which is the most common cause for cor pulmonale, and mostly driven by hypoxia and the hypoxic vasoconstriction. With regards to pulmonary hypertension, previously it was thought that pulmonary hypertension can lead to right ventricular failure, but the growing evidence is inconclusive, and now it is believed that although pulmonary hypertension may not contribute to the development of right ventricular failure, it will exacerbate right ventricular failure once it is established. Okay, after going through the anatomical and physiological, pathophysiological particularities, now coming to the diagnosis of right ventricular failure. So we need to combine the clinical as well as the imaging evidence in order to establish the diagnosis. And the clinical signs of right ventricular failure, they are many, some related to backward failure. And when there is backward failure, so important thing to remember is that there will be congestion. Okay, so the patient will have elevated central venous pressure with distension of the jugular veins and the raised JVP, and there will be organ dysfunction in the form of renal, hepatic, and GI impairment. The hepatic impairment is evident with the cholestatic pattern, and there is reduced intestinal obstruction and peripheral edema. When the patient also have forward failure, and the forward failure will usually uh, be evident by signs related to reduced left ventricular output in the form of low blood pressure and core clammy peripheries. ECG is very important in the initial assessment, and the clues pointing to right ventricular failure is right axis deviation, R to S wave in V5 or V6 of 1 or less, S wave in V6 or V5 is 7 or more, P pulmonale, and S1Q3 T3 pattern in acute pulmonary embolism. The patient can also have atrial fibrillation or atrial flutter. Here is an ECG. We see here that this is the right axis deviation. Here we can see that the axis is rightwards, and when we come to the chest leads, there is dominant R wave in the right precordial leads, and these are suggestive of right ventricular hypertrophy. And the classical signs of S wave in V5 or V6 of more than 7 we can see here, and the R wave to S wave ratio in V5 or V6 of 1 or less. So we can see that the R is small and the S is deep. So these are some of the signs, the ECG pattern that you can encounter in patients with right ventricular failure. Coming to imaging modalities, and the first and foremost important is echocardiography. It is important for many reasons, because it is easily available, and there is no risk to the patient with regards to radiation exposure or certain device related contraindications. But echocardiography should be comprehensive, and the assessment must include left ventricular function, assessment of the tricuspid valve, right atrium and pulmonary hemodynamics. Apical four-chamber views are the most important views, the short axis and the right ventricular outflow tract views. And the parameters which we usually calculate during echo assessment are TOPSY, the tricuspid annular plane systolic excursion, pulse tissue Doppler, and the right ventricular index of myocardial perfusion. This is a diagram in which give us a clue that these are some of the dimensions of the right ventricle in a normal patient, and we can see that the left ventricle is usually dominant, and the right ventricle is somewhat appears somewhat smaller than the left ventricle. But in cases of right ventricular failure, the right ventricle will be dilated, and its valve motion might be reduced. A comprehensive approach using a combination of these measurements, which we talked, the TOPSY, the pulse tissue Doppler, and the right ventricular index of myocardial perfusion, should be used, as none of them alone can adequately describe right ventricular function in different scenarios. 3D echocardiography and strain imaging have proven to be useful and accurate imaging modalities, but have limitations. Cardiac MRI and best for visualizing anatomy, quantifying function, and calculating flow, useful in cases where imaging quality by echocardiography is limited. It can provide advanced imaging with tissue characterization, which is useful in different cardiomyopathies such as arrhythmogenic right ventricular cardiomyopathy, storage disease, and cardiac tumors. However, MRI has its own drawbacks. For example, if the patient is claustrophobic or have certain type of intracardiac devices. When we talk about cardiac CT and nuclear imaging, they play a minor role. Although cardiac CT can help to visualize anatomy when MRI is not feasible. There are concerns regarding radiation exposure from both nuclear imaging and dynamic imaging by CT angiography. Okay, so in this slide we will discuss the medical treatment of acute right ventricular failure. The first thing that you should remember that every patient should undergo triage and comprehensive initial assessment in order to quantify the clinical severity and to identify specific causes that could be treated. Echocardiography and other imaging modalities are frequently essential to identify the cause of right ventricular failure and guide treatment. To prevent significant and irreversible tissue damage, rapid initiation of treatment to restore hemodynamics is essential. Okay, and now we will discuss the 4 elements of acute treatment one by one, and these 4 elements include volume optimization, restoration of perfusion pressure, improvement of myocardial contractility, and advanced options. So let's discuss them one by one. The first step in treating these patients is volume optimization. Classically, patients with right ventricular failure were treated with aggressive volume infusion, and the theory behind this strategy was that if we increase the right ventricular preload, the right ventricular output will increase. However, there are certain consequences of this aggressive volume infusion. Because the RV is already compromised, and if we increase the workload on the RV, it will further capitulate its function. So not every case should be treated with IV fluids. In certain instances of congestion, diuretics are used. Diuretics infusion or TDS doses may be required to relieve renal congestion, and sometimes diuretics response should be checked early during the course of the treatment. If the patient is not responding to diuretics, we can intensify the loop diuretics and add sequential nephron blockade by either starting the patients with thiazide diuretics or mineralocorticoid receptor antagonists. Volume loading should be guided by CVP monitoring. The second step is restoration of perfusion pressures, and this is done by vasopressors. And the vasopressor of choice in these patients is noradrenaline. It improves coronary, cerebral, renal, and splanchnic circulation. Target mean arterial pressure of 65 mm is reasonable, but it is sometimes required that we use organ-specific target mean arterial pressures, because the systemic mean arterial pressure may be misguiding, such as 50 to 70 mm of mercury for brain, 65 mm of mercury for renal perfusion, and more than 50 mm of mercury for hepatosplanchnic flow. If a patient doesn't respond to volume optimization and restoration of perfusion pressure, that is a patient with cardiogenic shock. Improvement of myocardial contractility can be attempted with the help of inotropic agents. And the agents include dobutamine, levosimendan, and phosphodiesterase type 3 inhibitors. Levosimendan and phosphodiesterase type 3 inhibitors are preferred. Adrenaline should be avoided because of the risk of arrhythmias and further deterioration of the right ventricular function. In addition, the advanced options, if a patient is not responding to the 3 mentioned strategies, is long-term oxygen therapy in patients with advanced COPDs, pulmonary vasodilators in selected cases, fibrinolysis for acute massive pulmonary embolism, and mechanical circulatory support devices in refractory cases, and palliation if long-term treatment options are not available. In this slide, I will go through mechanical circulatory support for advanced right ventricular failure. Classically, we use right ventricular assist devices. If RV failure persists despite treatment with vasopressors and inotropes, temporary right ventricular assist devices are very valuable as RV failure can be dramatically reversible. Some points to remember: how to maximize success with right ventricular assist devices, and importantly, optimal patient selection and optimal timings of our VARDS implantation are the key to success. Another point is appropriate device selection and the strategy to be implemented, whether it's a bridge to bridge, bridge to recovery, or bridge to transplant, and the need for oxygenator should also always be anticipated, and determination of both right ventricular and left ventricular function assessment is also important. Temporary right ventricular assist devices can be implanted both surgically and percutaneously. Percutaneous temporary right ventricular assist devices have an advantage that they can be used for early initiation of support without the need for surgery, and they are approved for a shorter period of time and can sustain a lower flow than surgical devices. They are of two types: the direct RV bypass system, the Impella RP and the tandem heart, and the indirect RV bypass systems such as the veno arterial ECMO. Surgical temporary right ventricular assist devices require an open sternotomy or thoracotomy for direct RA to PA cannulation, RA and PA cannulation, and their connection to an extracorporeal centrifugal flow pump. They allow more extended and greater support in terms of flow at the cost of an invasive implantation and removal. So this is a diagram in which different types of the right ventricular assist devices are shown. The indirect RV bypass is the VA ECMO, and the direct RV bypass systems can either be axial flow type or extracorporeal centrifugal flow devices. The axial flow device is the Impella RP, and the extracorporeal centrifugal flow devices are the Tandem, RVAD, and the Protect Duo. Here, normal blood flow through the right side of the heart and blood flow through the right ventricular assist devices are shown. Normally, we know that blood comes into the right atrium of the heart through the inferior vena cava and the superior vena cava. From the airway, the blood flows through the tricuspid valve into the right ventricle, which pumps the blood through the pulmonary valve into the pulmonary arteries. When we talk about an RVAD, we see here that the blood coming through the inferior and superior vena cava into the right atrium is channeled into the RVAD, and the RVAD then pumps the blood into the pulmonary artery, bypassing the right ventricle. Again, we see here that the RA is cannulated, blood is coming into this RVAD, which has a power source, and the RVAD is pumping this blood into the pulmonary artery, and the RV is bypassed. Those were the patients who needed temporary right ventricular assist devices. Now, certain patients will require more durable and long-term support, and the options for these patients are the isolated pulsatile RVADs, surgically deployed rotary flow RVADs, biventricular support with pulsatile ventricular assist devices, and total artificial heart replacement. However, cardiac transplantation remains the only successful long-term treatment because RVADs are more prone to complications. We know that the pulmonary pressures are very much less than those in the systemic circulation, so the RVADs are more prone to thrombotic bleeding complications and infections, and patients used to be hospitalized while on RVADs, and there are certain technical limitations. Few words about the arrhythmic aspects of right ventricular failure. Supraventricular arrhythmias such as atrial fibrillation, atrial flutter, or multifocal atrial tachycardias are associated with right ventricular failure, and they negatively affect the right ventricular filling and thereby contribute to the vicious cycle of aggravating right ventricular failure. Prompt rhythm control of supraventricular tachyarrhythmias is central in managing such patients, and the treatment of choice for these patients is prompt electrical cardioversion to restore the sinus rhythm, as rate control alone is not sufficient because AV synchrony and atrial contraction both are needed for adequate RV diastolic filling. Now, once we have restored the sinus rhythm, now how to maintain the sinus rhythm in these patients? Amiodarone is the drug of choice to maintain sinus rhythm. Avoid calcium channel blockers and beta blockers because of their negative inotropic effects. Also, class 1C antiarrhythmics as well as sotalol and dronedarone should not be used in structural heart diseases. If medical therapy fails, AV synchronous pacing with either the patient's indwelling device or transvenous pacing wires may be considered. The question arises that whether CRT or ICD has any role in patients with right ventricular failure. When we talk about cardiac resynchronization therapy, which is indicated as per the guidelines in patients with heart failure with reduced ejection fraction and a prolonged QRS, limited data is available on the role of CRT in patients with right ventricular failure. Several observational studies have demonstrated significant improvement in right ventricular function after cardiac resynchronization therapy, and the trial of note is the MADD CRT trial. The post-hoc analysis of this trial showed significant improvement in right ventricular fractional area change with CRT. On the other hand, the CARE-HF and REVERSE trials failed to show the benefits shown in MADD CRT trial. Similarly, scarce data is available on the role of ICD in preventing sudden cardiac death in right ventricular failure. Current guidelines do not recommend ICD therapy for primary prevention of sudden cardiac death in patients with isolated RV failure. Arrhythmogenic right ventricular cardiomyopathy is the only exception where ICD can be implanted in the presence of certain risk factors for sudden cardiac death prevention, primary prevention I'm talking about. Hemodynamically significant sustained VT or survivors of sudden cardiac death should undergo ICD implantation for secondary prevention. In summary, we can divide our topic into two sections: assessment of RV failure, which should include the anatomical and physiological particularities of the right ventricle, and appropriate imaging techniques to understand the underlying pathophysiological mechanisms, and the treatment, which include rapid optimization of volume status, restoration of perfusion pressure, and improvement of myocardial contractility and rhythm. In case of refractory right ventricular failure, mechanical circulatory support. Thank you so much. Thank you so much. Again, I will request you to please subscribe to Cardiology Vibes on YouTube and press the bell icon so that you receive notifications for our new videos. If you have any questions, you can write down them in the comment section or WhatsApp us in the number shown on the screen. Thank you so much again.